Okay. Again, Assalamualaikum warahmatullahi wabarakatuh. I think let's begin our session with Kitab al-Fatihah. Okay. Before we begin, I think you guys have not sent in your presentation, kan, to me?
Dah send.
Dah.
Doctor, I haven't emailed the full slides to you yet.
Please do send in all. Among the reason is I'm just looking at how many presentations are actually almost the same with the previous batches and the future batches as well. I'm not saying you copy or anything. It's just that I think it will be interesting to see how many percentage are similar among all the across the different batches of students. Okay, all right. Let's begin. Who's the presenter?
So, Bismillahirrahmanirrahim. My name is Najla binti Harun. So today I'm going to present two topics which are croup and also acute epiglottitis. So what is croup? Croup actually is an inflammation of the larynx, trachea, and also the bronchi, and also known as laryngotrachea bronchitis. It is a clinical syndrome that characterized by barking cough, inspiratory stridor, hoarseness of voice, respiratory distress of varying severity. So the etiology most commonly caused by the parainfluenza virus type 1, 2, and 3. Others RSV, influenza virus type A and B, adenoviruses, enterovirus, measles, mumps, and also rhinoviruses. Direct
Najla,
yes?
Name me one example of influenza virus type A.
Name?
One example of influenza virus type A.
Influenza.
Anyone wants to help her?
H1N1.
Yes, very true. So H1N1 is a type of
Influenza virus type
influenza
A.
virus. Yep. H1N1, H2N2, and then type B usually is basically it's a name lah. Name places. I can't even remember that means. Okay, fine. Proceed, Najla.
Okay. Okay, next. The pathophysiology of the croup. Actually, croup, the pathophysiology is that when the pathogen infected at the upper respiratory tract, and what happened is the pathogen cause the low-grade fever and also coryzal symptoms such as runny nose and also sore throat. And after a few days, the pathogen will infiltrate the larynx, which is the voice box, and also the trachea, and it will cause the inflammation reaction to be happen. And from the inflammation reaction, it will more trigger the edema, which is the swelling of the lumen, and it will result into the narrowing of the lumen. And this is picture. We can see the normal and also the inflamed larynx. So if you see at the left, the croup, different between the healthy airway and also the croup. So from the healthy airway, we can see that the lumen are more bigger compared to patient we have been infected as the lumen become narrowed due to the swelling. And then the clinical features, the early symptoms happen between 12 to 72 hours, which are low-grade fever and also coryzal symptoms. For the late symptoms, such as inspiratory stridor, which is the high pitch of whistling sound, barking cough, hoarseness of voice.
Najla, sorry.
Yes.
Describe, how do you describe stridor again?
High pitch. High pitch. Whistling sound.
High pitch whistling sound. How do you differentiate between stridor and ronkai? What is ronkai? What is
Ronkai.
wheezing?
Wheezing. So kalau sorry. So for wheezing, actually
What is the difference between stridor and wheeze?
Inspiration and inspiration.
Okay. Again, who's trying to say that? Do you mind? Siapa yang cakap tadi?
Me.
Azhan.
Yeah.
Okay. Tell us a bit more.
Usually, we can hear it on expiration, meanwhile wheezing on inspiration.
So wheezing is on inspiration, and wheezing is expiration. Stridor is inspiration. Okay. Other than phase of respiration, what are the other difference between stridor and wheeze?
Inspiration occurs extrathoracic, meanwhile expiration intrathoracic.
Okay, good. Why?
Why? Because couldn't remember the facts.
Okay, what are when you auscultate or when you hear, when you listen to it, what's the difference between stridor and wheeze other than the phase of respiration? Apa lagi?
The location.
Location, fine. So the pitch, frequency, pitch is a representation of frequency, isn't it? Higher frequency meaning higher pitch, kan? So which one has higher pitch? Stridor or wheezing? Huh?
Wheezing has a higher pitch.
Yes, wheezing has higher pitch. Stridor has lower pitch. Stridor is sort of like, is almost like a grumbling sound, almost macam snoring.
Hoarse sound.
Bunyi itu very hoarse. Bunyi dia kasar. Macam tu. Wheezing ni bunyi macam whistling. Whistling high pitch sound is wheezing. He. That is wheezing. Stridor is almost macam snoring. Macam tu. That is stridor. It's a low pitch, high amplitude sound. So what causes stridor and wheezing? What causes stridor and wheezing?
Maybe because of the narrow of the airway, so it causes the turbulence of the airflow.
Yes, true. So all these are sounds. What causes sound? What causes sound? Sound is caused by vibrations.
Vibration.
So vibration in the air, vibration in fluid, vibration somewhere. So this vibration is transmitted through our ear, isn't it? And then it's transmitted into the brain. So all these are vibrations. So vibration produce sound, isn't it? Vibration produce sound. Okay, so when the vibration very high frequency, the pitch will be high. It will be whistling type of sounds. But because why? Very high pitch, very high frequency. When very high frequency, the sound will be very high pitch, very macam shrieking sound, whistling sound. So that is high pitch. Bila lower pitch, dia akan jadi that is low pitch sound, kan? Because of vibration dia lower pitch, lower frequency, kan? Okay, and then why in stridor, or stridor means it's upper airway, isn't it? It's extrathoracic. Extrathoracic, upper airway is inspiratory. lower airway is become wheezing. Can it be expiratory stridor? Can or cannot?
Cannot.
Huh?
I'm not sure. Tapi from the reading, I think cannot.
So if you know me, yeah, you all don't know me yet. Can is a very bad question. Usually, if the question is can, the answer is always can. So because everything in the world it's can something. So can is never a good question. So if I ask you can, the answer will always be can. Okay, fine. So stridor, inspiratory is just phase. So it can be monophasic stridor, which is inspiratory stridor, or it can be biphasic stridor. So in a more severe upper airway obstruction, it may be biphasic stridor. Same as rhonchi as well. It can be monophasic phase, only one phase, monophasic rhonchi or monophasic wheeze. But when it's severe, it becomes biphasic rhonchi or biphasic wheeze. What is the difference between wheeze and rhonchi? Apa beza wheezing dengan rhonchi? Sama ke? Different ke?
Rhonchi can be heard during auscultation.
Siapa yang try cakap tu?
Hidayah.
Hidayah. Macam mana Hidayah? Aku cerita sikit.
Rhonchi can be heard during auscultation. Wheezing, we can hear it without auscultation.
Okay, good. That is the usual interpretation by us lah. But actually, wheezing and rhonchi are both English words, which means the same. Whether it is auscultated or whether it's audible, it's still the same. You can even say audible rhonchi, you can say audible wheeze. So it's basically super, it's tulo, bedok tulo. It's basically the same thing. Wheezing and rhonchi is basically the same thing. Usually rhonchi is used more medically, so it's used by it's a medical term, but wheezing is a layman's term. Maknanya orang kampung pun boleh cakap wheezing lah. Orang kampung dekat Bicester lah, bukan orang kampung kat sini kan. Orang kampung kat Leicester kan, bukan orang kampung kat Pantai ni. But it's a layman's term. Wheezing is a layman's term. Okay, next. Why? Kenapa? Bila dia lower airway, it become expiratory and it's wheezing, rhonchi. Bila it's upper airway, it's more of inspiratory and it's stridor. Siapa-siapa nak try and answer or give a idea? Azri, you suddenly appear in my, so dalam my photo ni sekarang nampak Najla, nampak Hidayah, lepas tu Azri. So you are the only one that I'm going to ask lah, Azri.
Ada tak?
Kenapa? Aku cerita sikit.
From what I understand, maybe because of the upper airway compared to lower airway, dia punya diameter dia a bit different. Upper airway, dia punya diameter dia a little bit larger compared to lower airway. Okay. So due to obstruction, so yang lower airway ni will produce more turbulence flow compared to upper. So dia punya produce sound dia lagi kuat compared to above upper.
Okay, good. Yes. So when you have a larger caliber lumen, if you have turbulence, the turbulence will be a low frequency turbulence kan. Tapi kalau you ada turbulence tapi dalam lubang yang kecil, dia akan jadi very small ultra frequency punya turbulence kan. So this small frequency is high frequency turbulence. Yang tu menyebabkan dia jadi wheezing kan. So kalau dia besar kan, so the frequency will be bigger lah kan. Kalau dia punya velocity is the same, velocity of the air, velocity of the fluid is the same, but different caliber. Same velocity, different large caliber, low frequency, same speed. Tapi sebab large caliber, dia jadi apa? Dia jadi low frequency. Kalau same velocity, small caliber dia jadi very high
High frequency.
Bila high frequency, you get all this wheezing lah. Okay, one thing. And then, kenapa inspiratory, kenapa yang ni expiratory? Awak tang tu respiratory, awak tang tu expiratory, awak tang ni inspiratory. Siapa pula? Amir Zack. Oh, siapa tadi? Cuba nak jawab. Azri yang nak ke Samba tadi? You're trying to answer something.
Saya nak try. Tak tahu
Okay,
saya.
alright, try. Boleh.
Saya rasa apa contoh macam stridor, dia more on inspiration sebab dia blockage dekat upper part of respiratory tract. So turbulence tu afterwards tu yang dengar more on inspiration. Faham ke?
Okay, betul. Okay, you get the idea. Okay, because inspiration is an active process. Inspiration is active. Ada effort. You mesti, your chest must create a negative pressure for air to come in. It's an active process. You kena sedut air in. This is an active process. So bila ada obstruction in upper airway, bila you sedut air in across a obstructed punya airway, kan? After the turbulence tu akan jadi, after the obstruction tu dia akan jadi turbulence lah. Kan? So that's why inspiration. But expiration is a passive process. Expiration is passive recall. You don't know when you expire. Tiba-tiba dah expire dah. Kan? So it's a passive recall. So bila passive recall ni dia kohor-kohor lah. So bila kohor-kohor, dia tak jadi banyak turbulence lah. And because your upper airway, it opens out into the environment. So from a smaller lumen, it goes into a larger lumen. So bila larger lumen, berapa banyak pun dia punya turbulence tu, you tak dengar sebab dia dah keluar. So you won't appreciate that much. Tapi kalau it's severe, bila it's severe, even passive recoil pun akan cause turbulence flow. When it's severe, even to expire, you need some force. You need effort to expire because it's severe obstruction. So bila it's a forceful, it's an active expiration, baru turbulence flow created. Sebab tu you dapat biphasic stridor. Faham? Okay. Kenapa wheezing expiratory?
Sebab dia narrowing of lumen tu dekat lower part.
Yes, okay. So kenapa masa inspiration dia tak ada sound?
Sebab bila dia inspiration, lepas tu turbulence tu sangat, distance turbulence tu dengan tempat kita exchange air sangat dekat.
Because
so dia tak bunyi.
It's distal already, isn't it?
For
cases macam apa yang cause wheezing? Usually macam asma, or bronchiolitis, or micro aspiration, kan? All these causes or foreign body aspiration yang small, besar ni tak, yang small foreign body aspiration. This can cause wheezing sound. So why wheezing sound? Sebab dia dekat distal part of the airway. So kalau turbulence flow created pun it's not that much sebab it's a small confined area. So masa inspiration not that much. Tapi bila expiration, isn't it? Bila expiration, sebab itu bila obstructive airway disease, dia macam nak even expire tu dia ada prolonged expiratory phase sebab dia expire against an obstructed punya airway, lower down. Kan? So you expire, dia ada FEV, prolonged FEV1. Sebab apa? Sebab dia you expire across an obstructed airway. So and then daripada bronchial tu nak sampai ke trachea ni punyalah jauh track dia nak boleh jadi turbulence tu kan. So that is why you hear expiratory rhonchi. But when it's severe, you will have biphasic rhonchi. Okay, clear? Understand? That's why I always tell students, understanding pathophysiology is very important. Okay, remind me after this two presentation, after this both presenters, kita discuss a bit about the other sounds that you can appreciate in respiratory examination. Okay, alright, Najla, sorry to disturb you. Proceed.
Okay. Next, the signs. From the inspection, we can see that signs of the respiratory distress, tachypnea, tachycardia, nasal flaring, expiratory grunting, head bobbing, and recession, central cyanosis due to the severe hypoxemia because of the obstruction, so the reduce of the oxygen, and use of accessory muscles. And then auscultation, there will be reduced breath sound and expiratory bronchi, as Dr. mentioned. And then how can we assess the severity of this group? First, there's 3 levels: mild, moderate, and severe. So for my patient, there will be stridor at rest and during at site, and there will be no respiratory distress. For moderate, there will be stridor at rest and also recession. And severe, there will be stridor at rest, there will be marked recession, and there will be reduced air entry and altered level of consciousness. Next, so how we want to diagnose Croup? So actually Croup is clinically diagnosed. So if patient presented with the 4 symptoms of the Croup, so we can diagnose. So usually we visualize the pharynx in order to rule out retropharyngeal abscess and also acute epiglottitis. And we visualize the pharynx in the severe Croup, and we did it in ICU. And then we check for the neck radiograph in order to rule out the foreign body. So what is the investigation that can be done? First, we can send for blood, which is FBC, and also ASR. We can do pulse oximetry, laryngoscope in order to rule out the peritonsillar abscess, and we can do neck radiograph and look for the steeple signs. So what is steeple signs? Actually, is a wine bottle signs that refer to the tapering of the upper trachea on a frontal chest radiograph, resemble the church steeple. So this is the picture. So so if you can see, so this is the steeple signs. Okay, next. Okay, management and treatment. How we manage and treat the patient that been diagnosed with Croup. So the indication of the hospital admission. So the patient who have a moderate and also severe viral Croup, based on the assessment, the age less than 6 months, patient with poor oral intake, toxic and sick appearance, and have a long distance from the hospital. And so this is the treatment. We divide into 3, which is mild, moderate, and severe based on the assessment before. And so for my patient, we give the dexamethasone or prednisolone or nebulized budesonide. If the patient improve, okay, we send patient home. Usually my patient is mild. Usually patient who are mild is an outpatient. So for moderate, we will give dexamethasone, nebulized budesonide, or we can give both. And if patient not improve, we give nebulized adrenaline. And for severe patient, we give nebulized adrenaline, dexamethasone, nebulized budesonide, and also oxygen. And if the patient is not improved, we intubate and ventilate the patient, and then we give nebulized adrenaline. So then we proceed with acute epiglottitis. So what is acute epiglottitis? Actually, acute epiglottitis is an inflammation of the epiglottis and its surrounding structure, and it most common in children at the age 1 to 6 years old. So as we know that the function of epiglottis actually is to close the airway when we want to swallow the food, right? So we look for the normal picture. This is the epiglottis as it have been labeled. So, and the surrounding is, we have the trachea, vocal cord, the tongue, esophagus, and vestibular fold. And below the epiglottis, we have actually the larynx. So this is the normal epiglottis, and this is the infected one. So you can see that the swollen epiglottis here. Okay. Next. So the etiology is Haemophilus influenza B, group A, B, and C streptococci, strep pneumonia, Klebsiella pneumoniae, and Staph aureus. And next, what is the pathophysiology? Okay, first, when the pathogen, the pathogen
Najla,
invade. Yes.
banyaknya spelling error ni, penat.
Mana?
Tak apa. Nanti tengok balik.
Epiglottis. Oh, okay, sorry Atta. Okay. So first, the pathogen will invade the epiglottis, and it invade directly into the loosely attached submucosa membrane. And when it invade, it will cause inflammation reaction to be happen. And when it it invade the submucosa membrane, as we know that there are 4 level, mucosa, submucosa, right? So at the submucosa, so there will be a capillary. So when it invade at the capillary, and it will goes to the bloodstream and it cause the bacteremia. So this inflammation will result in edema of the epiglottis and its surrounding tissue. When the epiglottis swollen, so it will cause the obstruction. Okay. So this is the clinical features, there will be symptoms and signs. So because the acute epiglottitis is very life-threatening, so it will presented with high-grade fever. Patient will have a difficult to swallowing, which is dysphagia, have a drooling of saliva, noisy breathing, hoarseness of voice, and followed by shortness of breath. And the uncommon is the cough. And for the signs, generally a patient will look very ill and toxic looking, sit immobile, upright and open mouth in order to optimize the airway. We call as a tripod position. And this one will be stridor and sinuses. Okay. And the examination, we cannot do the throat examination because it will cause more danger. If we do the throat examination,
Obstruction.
patient can can it can cause death to patient.
Due to obstruction.
Because of the obstruction. Okay, so this is the investigation. So before we investigate the patient, we have to make sure that the airway we have to make sure that to secure the airway. So after we secure the airway, so we can send for the blood investigation such as for blood count and blood culture and sensitivity. And we can do the laryngoscope. So from the laryngoscope, we can see that as the picture. So this is the picture of the epiglottis. So you can see that the swollen epiglottis and its surrounding and the hyperemic colors. And next we can do neck radiograph. So from the neck radiograph, so we can see the thumbprint sign. So this, okay.
Thumb sign lah, not thumbprint sign, thumb sign.
Okay, thumb sign. Okay.
Thumbprint tu cap jari.
Alright. Okay, what is thumb signs? Actually, it is a manifestation of an edematous and also the enlarged epiglottis, which we can see from the lateral tissue of the radiograph. So it different from the group, which group we can see it from the front, right? So, okay. So from the thumb signs, it's for epiglottitis and steeple sign for Croup. Okay. So what is the management and treatment for acute epiglottitis? First, we have to admit the patient to the hospital urgently, and then we transfer the patient to the ICU and or anesthetic room. in case patient have a respiratory obstruction, and then we request the tracheostomy or endotracheal intubation in order to secure the airway, and we administer the high flow humidified oxygen saturation and monitor the respiratory and cardiac problem because patient might have a respiratory arrest. So and then we patient should be supervised by all the time by the medical staff. So what treatment we give is we give the IV antibiotics, second and third generation of cephalosporin, which is ceftriaxone and also cefotaxime, and we give flucloxacillin. And another one we do the tracheal we do the tracheal tube, which is tracheostomy. We insert the tube into the trachea in order to allow the patient to breathe in and out. And then,
Najla,
yes?
do you give all? Which antibiotic you want to give?
Oh, ada dia.
You nak bagi cephalosporin and flucloxacillin? Is it?
Yes.
Sure. Why?
So because patient be infected, I think because second and third generation is more like broad spectrum antibiotic, so it can cover semua.
Okay, so why not just cephalosporin? Why do you need flucloxacillin?
Flucloxacillin in patient who have been infected with staphylococcus LTB.
Okay, my point is, first you don't usually do polypharmacy. So if you do polypharmacy, you need to think why do you need to cover with polypharmacy. So if you give more than one type of antibiotic, you need to think hard why. Especially cephalosporin and cephalosporin, cloxacillin. Now these are all penicillin group. These are all beta-lactamase. So the coverage is almost the same. So obviously, flucloxacillin is very good for staph. It's very good for staph. So, but the thing is, cephalosporin also has coverage for staph as well. What's the difference between first generation, second generation, third generation, fourth generation cephalosporin? Apa difference dia? So cephalosporin ni, first generation siapa ada idea one type of first generation cephalosporin?
First generation cephalaxin first generation.
Cephalaxin, yes. Cephalaxin is a type of first generation cephalosporin. So first generation cephalosporin, it has good coverage for gram positive. Example of second generation cephalosporin?
Cefuroxime.
Cefuroxime or Zinacef or Zinat. So these are second generation cephalosporin. So second generation cephalosporin has better coverage for gram negative as well as almost equal coverage of between gram negative and gram negative. Third generation, example of a third generation cephalosporin? Ceftriaxone or Rocephin. Satu lagi? Ceftazidime or Fortem. Yes, Fortem is basically useful for infection yang macam mana? Pseudomonas. Pseudomonas usually we reserve ceftazidime or Fortem ni for Pseudomonas infection. So cefotaxime, claforan. So cefotaxime ni nama dia claforan, brand name dia. So this is another third generation cephalosporin. So or cefobit. Cefobit is cefoperazone. And so third generation has more gram negative coverage than third generation has more gram negative coverage as compared to second generation. Anyone knows any example of fourth generation cephalosporin?
Cefepime.
Apa? Cefepime, yes, Cefepime. So Cefepime or Maxipime, brand name dia Maxipime. So this is fourth generation cephalosporin. Ataupun Cefdiel, Cefdinir. So these are fourth generation cephalosporin is more gram-negative coverage. Okay, Najla, proceed. Sorry kacau. I'm still gonna kacau.
Sekarang dah ada 5th generation ke tak
Ada.
guna?
Dah ada 5th generation tapi tak guna lagi kat Malaysia. Sebenarnya expensive. Even 4th generation pun susah nak dapat.
Okay.
Proceed.
Oh, thank you. Done already.
Anyone has seen acute epiglottitis? So I've been a doctor for 14 years. I've never seen acute epiglottitis. Acute epiglottitis is among the scariest condition a child can be in. As a doctor, if you ask me one condition that you don't want to see a patient, it is acute epiglottitis. Because it's among the most severe condition. The child will be very toxic, very ill-looking. The child can't breathe. Dia macam lemas. He's struggling, strangulated. He cannot breathe. So dia akan duduk in tripod position, neck extended, and then dia breathe. Dia buka mulut, dia breathe. Because it's very difficult to breathe. So dia macam lemas in his own body. So acute epiglottitis is among the most severe, it's among the most scariest condition a child can be. And then obviously if you pergi sibuk nak examine the throat, what's going to happen? You will stimulate more. You can stimulate the vagal response. Kan? Vagal response causes obstruction, causes basically it can cause more airway constriction. Kan? So be careful. So acute epiglottitis is among the most scariest condition. Viral croup is very common. If there is most of the time, most of our exam, some of you will definitely get viral croup. That's the thing. With viral croup, you need to know what questions to ask. So hoarseness of voice, barking cough, stridor. These are questions that you need to know and ask. Okay? Kena tanya questions tu. And then how to differentiate between stridor and snoring? How to differentiate between stridor and snoring? Is it the same? Stridor and snoring, sama ke lain? Siapa yang ada experience snoring ni?
Snoring waktu tidur.
Snoring waktu tidur. Betul.
Stridor bila masa.
Snoring is when you sleep. Because bila you sleep, the back of your tongue ni fall back and covers your upper airway, covers your epiglottis and things. So this is because of, it all happens only when you sleep. No one snores when you're awake. There's no such thing as awake snoring. So snoring happens when you are asleep. It's affected by position and things. But in viral croup, the stridor, it happens all the time. Whatever position you change pun, dia still akan ada that stridor. As compared dengan things macam, apa lagi? Okay, what are other causes of stridor? Differential diagnosis for stridor. So snoring, kan? Snoring. Lagi, apa lagi? Viral croup, okay, epiglottitis, lagi apa lagi? Differential diagnosis for stridor.
Foreign body aspiration.
Foreign body expression, if it's a big foreign body and it obstructs the larger airway, trachea, main bronchus, kan? Okay, lagi?
Tracheitis.
Tracheomalacia.
Tracheomalacia, yes, tracheomalacia, true. Okay, tracheomalacia ni in which sort of patient boleh dapat tracheomalacia?
Down syndrome.
Down syndrome.
Down syndrome, okay, lagi? Patients who was ventilated. Patients who was ventilated for a very long time. So bila dia intubated kan, sometimes it causes the expansion pressure tu dekat dia punya trachea. So trachea dia akan more friable, dia akan lebih ni. So this causes tracheomalacia. Okay. What else? Apa lagi? Differential diagnosis for stridor.
Laryngospasm.
Ah? Apa?
Vocal cord paralysis.
Vocal cord paralysis. Yes, true. Name me one surgery that the complication is vocal cord paralysis.
Thyroidectomy.
Thyroidectomy. Yes, true. So if you have a patient with thyroid problem and then you have stridor, then you know this is vocal cord issue because vocal cord dia ada curve dekat dia punya ni kan.
Recurring laryngeal nerve.
Yes. Okay. What else? Differential diagnosis. This is fun, isn't it?
Peritonsillar abscess.
Peritonsillar abscess. Okay. Yes, true. Good. So apa akan jadi kalau if you have a patient with peritonsillar abscess, what's going to happen?
The tonsil will inflame.
One feature. Okay, inflamed tonsil. Okay.
And obstructed.
Of course lah, obstruction. Stridor obstruction lah kan. It will be very foul smelling. The moment the patient open his mouth, it will be very foul smelling. Okay. Apa lagi?
Laryngospasm. Laryngospasm.
Laryngospasm. Okay, yes, laryngospasm. Okay, good. Okay. Example laryngospasm?
Due to anaphylaxis reaction.
Yes, very true. For example, macam apa can cause anaphylaxis reaction? We have this patient. We have a patient with this risk 3 weeks ago. No, 4 weeks ago. Oh, probably more.
Bee sting.
Hornet sting. And bee sting as well lah. Hornet sting, bee sting. So basically Hymenoptera sting. So bee, hornet, fire ant, these are among the family of Hymenoptera. So Hymenoptera, bee, hornet, fire ant. Okay, yes, what else? Apa lagi? Banyak lagi ni stridor.
Thyroid CA.
Okay, fine. You don't expect thyroid CA in children lah. Tapi okay, fine. What else?
Tracheitis.
Tracheitis, okay, yes, fine, yes, boleh. Okay, lagi?
OSA.
Obstructive sleep apnea. Obstructive sleep apnea usually stridor ke ataupun snoring?
Snoring. It
shouldn't cause stridor lah kan biasanya. Okay, lagi? Lain, I'm waiting for more common punya differential ni. Tak muncul lagi.
Common.
Croup Najla dah cerita kat kita. What else?
Allergic.
Allergic anaphylaxis, okay.
Hemangioma, doktor.
Hemangioma, okay, yes, very true. So hemangioma can also happen. Kan? So sebab tu kalau patient yang ada banyak hemangioma besar-besar, you need to look at the airway dia. Sometimes there can be hemangioma there. Vocal cord hemangioma. Okay, what else? I just saw one patient in clinic today.
Infectious mononucleosis.
Infectious mononucleosis, and then what does it cause?
Edema.
Edema, okay. Apa lagi? Banyak ni.
Laryngeal.
Down syndrome. Down syndrome. Apa boleh ada? Laryngomalacia lah. Laryngomalacia. Kan? Laryngomalacia. So laryngomalacia is among the commonest cause lah. Apa lagi? Kalau patient nak intubated lama, then you extubate, what's gonna happen? You intubate, Lepas tu you cause stimulation dekat that area, irritation, causing inflammation. And then fibrosis formation. Subglottic stenosis. Below the glottis, epiglottis, bawah dia ada glottis. Epiglottis, vocal cord, glottis, bawah itu is subglottic kan. So subglottic stenosis because of your ET tube tu irritate the subglottic punya area, subglottic stenosis. Lagi, something that you give vaccination at 2 months.
Diphtheria.
2 months. Diphtheria. Yeah. Exactly 1 year ago. Not exactly 1 year ago lah. 1 year and 2 months ago. No. 1 year and 4 months ago. So 1 year and 4 months ago, we've had a patient who's the parents are anti-vaccine punya group, tapi they only receive 1 vaccine. Came in with, oh this is recorded kan? Tak apalah, fine. So and then the patient came in with stridor. And the moment I look into the throat, I saw this lots of webbing, ada macam whitish mucus, sticky, and very bad stridor. So could it be diphtheria? So diphtheria is a very complicated punya ni lah. Diphtheria you kena bagi toxoid dia apa semua. So diphtheria is a problem. Diphtheria is also another scary punya problem. Okay, so stridor is something that you need to know lah, how to differentiate. So stridor is something that you need to know how to differentiate. Okay, alright. Any other question? To the presenter lah, not to me.
Can I ask?
Siapa nak tanya Najla tu? Yes.
Akmal.
Okay. Why in acute epiglottitis we cannot examine the throat, but in croup it is permissible?
Najla, why?
Sorry. Okay. So maybe because in acute epiglottitis, the patient had a very severe obstruction. So if we do the throat examination, it will worsen the condition. In acute epiglottitis, as we know that epiglottitis is function to close the airway, right? So when it been infected, it's swollen as the picture I showed before. So it cause a really was narrowing of the airway. But in the group, so the narrowing of the it will cause the narrowing of the lumen, but the epiglottitis is not affected really.
Okay.
Tak tahu nak.
Hai, cubit dia nak dengar. Okay, so basically I've told you before. Okay, acute epiglottitis is among the scariest presentation for any children ever. If you ask me as a pediatrician, as a consultant, if there is one disease that I don't want to see ever, is this acute epiglottitis. So because the patient will present extremely severe. So the moment you probe the throat, I mentioned just now kan, the moment you probe the throat, you kosek kat situ, what's going to happen? There will be vagal stimulation, there will be more irritation, more inflammation, patient will collapse. You tak ada option melainkan you tebuk dia punya tekak dia. You cannot even intubate because it's so severe, the edema. You kena do tracheostomy. Do you like to perform tracheostomy? Of course you shouldn't like kan. I've done once I've done several times in newborn babies. I don't like it at all. And so it's not something good. So that's why if you want to examine the throat in epiglottitis, you must do it first. Why do you need to examine the throat? Kan? So if you do one, you cannot sleep without actually looking at the throat, then make sure you do it under anesthetic guidance. Okay. Can you examine the throat in croup? Croup has mild, moderate, severe. If it's mild croup, you buatlah apa-apa nak buat. You letak siku kat tekak pula tu pun okey, tak ada masalah. Janganlah buat kan. But what I'm trying to say is if it's mild croup, it's okay. But if it is severe croup, why do you need to probe the throat? Again, croup as well, whatever it is, if you probe the throat, if you kosek-kosek kat throat dia, there will be vagus stimulation. When there's vagus stimulation, there will be more airway obstruction. Kan? So kalau dah severe croup, kenapa nak kena kacau-kacau throat budak tu? Biarlah. Kan? So sama juga. So the point, okay. One thing I need to be very clear, and Najla cerita, in viral croup kita boleh buat, kita boleh tengok throat dia, kita do full blood count, kita buat test, kita buat x-ray semua. Do you actually need to do those things? Do you actually need to do it? Kenapa kita nak kena buat FBC? Kenapa nak buat FBC?
To look for the white blood cell count.
But you know it's viral croup. Nama pun dah viral croup. Dia bukan bacterial croup kan. Nama dia is viral croup already ni. So?
Bacterial superinfection. Bacterial superinfection.
Very quite uncommon juga in croup.
So exclude ada
FBC. Clinical diagnosis je sebenarnya.
Yes, viral croup is a clinical diagnosis. If you examine the patient, viral croup, it should be low grade fever. It shouldn't be very high grade. So if by history and basic examination, you know already this is viral croup. Then kenapa nak buat FBC? Kenapa nak buat CRP? CRP is 30 ringgit per test. FBC is easily 15 ringgit per test. Who pays for this? Kan? Ni lah, taxpayer. You all tak bayar tax lagi. Kan? It paid by taxpayer, it paid by the patient. Kan? So people are gonna pay for it. Someone is paying for it. Kan? So kenapa nak kena buat all these tests? Kenapa nak kena buat blood culture? Kenapa nak kena buat x-ray? If you already knew, kalau tahu dah it is viral croup, kenapa nak kena buat x-ray? Just to prove that there is a steeper sign. So what? Will it change your diagnosis? No, unless you're not really sure. Could it be foreign body? So okay, foreign body, if you do x-ray, you can probably see something. You can see a coin ke, you can see something, and you can see peanut ke sometimes, and you can see something kalau you buat x-ray. So the point is, whenever you order something, use your brain. Use your brain. Kan? Don't ever request something without using your brain. Think first. It is in medicine there is nothing. Dia bukan macam AI. Dia bukan macam datang dengan ni kita buat ni. No, it's not like that. In medicine you need to think. You need to clinically correlate. You need to think why you need to do something. Why you need to do this test. Why you need to treat like this. So always think. Good clinical judgment, good clinical acumen. So benda ni yang nak kena fikir. Okay. Alright. Clear. Okay. Let's go to the next presenter kat ke-10 dah. Yep. Next. (26 slide). Okay.
Bismillah, Assalamualaikum warahmatullahi wabarakatuh. My name is Susna Hayati and I will be presenting about the childhood pneumonia. Boleh dengar ke? Okay. Next, what is childhood pneumonia? Pneumonia is the inflammation of the lower respiratory tract that involves the airway and the parenchyma of the lung with consolidation of the alveolar spaces. So simply means that the pneumonia is the inflammation that can cause consolidation of the lung. So what is the consolidation? The consolidation means the solidification of the lung tissue due to the accumulation of the solid material in the alveolar spaces instead of air in the alveolar, such as the accumulation of pus, accumulation of blood and also exudate material. Next is the type of pneumonia. There are bronchopneumonia, lobar pneumonia, and also interstitial pneumonia. First is the bronchopneumonia. Bronchopneumonia is the inflammation of the lung that is centered in the bronchioles. So what happens when it is there is inflammation at the bronchioles? It can cause the production of mucopurulent exudates, and this will lead to the obstruction of the small airways, and this can lead to the patchy consolidation in bronchopneumonia. As for the lobar pneumonia, it is the pneumonia that localized to one or more lobes of the lung. And the interstitial pneumonia, it is the inflammation of the interstitium that composed of the walls of the alveoli, the alveolar sacs and ducts, and also bronchioles. And the interstitial pneumonia is the characteristic of the usually associated with viral pneumonia. Next is the pathogenesis of the pneumonia. It started with the infection of the lung either by the bacteria or viral or other pathogens, and it will initiate the inflammatory response to the lung, and it leads to the alveolar edema and also can lead to the exudate formation. So this will fill the alveoli and also the respiratory bronchioles with serious exudates, blood cells, fibrin, and also bacteria, and lead to the consolidation of the lung tissue and cause pneumonia. So next is the etiology of pneumonia. It can be grouped by the pathogen or the age of the patient. So for the pathogen, it can be caused by virus, bacteria, and fungal, and also others. But in 40 to 60% of the cases, the specific pathogen cannot be identified. But in the majority of the cases, the pneumonia is caused by the virus, and the bacterial cause is more common in older children. And the age is a helpful indicator to predict the etiological agent. So this is the pathogen that can cause pneumonia. As for the bacterial, the Streptococcus pneumonia is the most common bacterial cause of pneumonia. And for the Mycoplasma pneumonia and also Chlamydia pneumonia or Chlamydia pneumonia, it is considered as atypical pneumonia. And for the Haemophilus influenza type B, it is more common in an immunized patient. And other bacteria is Chlamydia trachomatis, gram-negative enterics such as the Klebsiella and also E. coli, and also Moraxella catarrhalis. As for the viral, the most common is the respiratory syncytial virus, and also other respiratory virus such as the influenza A, B, parainfluenza virus, human metapneumovirus, and also adenovirus. As for the CMV, varicella, and herpes virus, it's more common in immunocompromised patients. And also other viruses that can cause pneumonia is coronaviruses, such as the SARS, MERS, and also COVID-19. Next,
Husna.
Yeah,
COVID-19 is the name of the disease, not the name of the virus.
Oh, okay. SARS-CoV-2.
SARS-CoV-2. So sama juga. SARS ni nama virus dia is SARS-CoV. MERS ni nama disease dia. Nama virus is MERS-CoV. So COVID-19 nama virus dia is SARS-CoV-2.
Okay. Next is the fungal causes such as the aspergillosis, Pneumocystis jirovecii, and also Cryptococcus neoformans, and also Mycobacterium tuberculosis. These pathogens are more common in immunocompromised patients. And as for the Pseudomonas aeruginosa, it is usually associated with patients with cystic fibrosis. And other rare causes is the rickettsia infection and also parasitic infections such as the ascariasis and also strongyloides. And so the pathogens can also be grouped according to the age of the patient. As for the neonates, less than 3 weeks, the common common pathogen are the group B Streptococcus, E. coli, other gram-negative bacilli, Streptococcus pneumonia, and also Haemophilus influenza. As for the patient 3 weeks to 4 years old, the common viral are the respiratory syncytial viral, and also other respiratory virus such as the influenza virus, and adenovirus, and also the Streptococcus pneumonia and Haemophilus influenza. The Haemophilus influenza is more common in a patient who is an immunized patient, and in a patient in infant, if the patient is febrile, we need to consider for chlamydia trachomatis infection. As for the atypical pneumonia, such as the mycoplasma pneumonia and also chlamydophila pneumonia, it is more common in patients more than 5 years old. Okay. Next is the clinical features of pneumonia. For the neonates, the clinical features of pneumonia is usually subtle and also non-specific, such as fever, lethargy, and also apnea. As for the infants and children, the most common clinical presentation of pneumonia is fever, cough, and also tachypnea. As for the viral pneumonia, the patient may present with milder fever and may be preceded by URTI symptoms such as the runny nose. As for the bacterial pneumonia, patient may present with higher fever, associated with chills, and also more toxic looking. And other symptoms includes the malaise and also poor feeding, and also localized pain such as the pleuritic chest pain, abdominal or neck pain, and this usually indicate bacterial pneumonia, as this can lead to pleural irritation. And for the atypical pneumonia, the patient may have the extrapulmonary manifestation such as conjunctivitis in chlamydia trachomatis patient, and also the patient might have a low-grade fever. Next is the physical examination.
Wait, I have one question.
Yeah.
Name me one atypical pneumonia, one cause of atypical pneumonia that can cause anemia.
Cause anemia.
Atypical pneumonia causing anemia, low hemoglobin.
I don't know.
Anyone has any idea, suggestion? This question come up in my third year exam in 2002, 2003. I think 2003, third year exam.
Mycoplasma pneumonia.
Mycoplasma pneumonia, yes, very true. So mycoplasma is a known cause for anemia. What type of anemia?
Hemolytic
anemia.
Okay, what type of hemolytic anemia?
Severe
Autoimmune hemolytic anemia. Kan? IHA, mycoplasma causes IHA, autoimmune hemolytic anemia. Then my next question will be, what type of IHA? Dia ada cold IHA, dia ada warm IHA kan? Sudah, tak ingat dah?
Cold IHA.
Oh lah, warm IHA lah.
IHA.
Okay.
Cool IHA.
Not cold lah, bukan cold. Satu lagi tu.
Warm.
IHA.
Okay, fine. Okay, proceed.
Okay, next is the physical examinations and the signs of pneumonia. As for the infection, the patient might have increase in respiratory rate, and also signs of respiratory distress, such as grunting, nasal flaring, intercostal and subcostal, and also supraesternal retraction, and also use of accessory muscle. And the patient might have reduce in chest expansion and also dullness on percussion. The patient might also have a decrease in breath sound, bronchial breathing, and also an inspiratory cross record. So we need to also assess the severity of pneumonia, and the severity of pneumonia can be assessed according to the general to to it, and also the level of consciousness of the patient. As we can see here, the signs of respiratory distress, such as the chest indrawing, it indicates severe pneumonia. Next is the investigations of pneumonia. First is the chest radiograph, which is the chest X-ray. So the chest X-ray we usually do in when the clinical criteria is suggestive of pneumonia, but the radiography alone cannot provide a definitive microbiology diagnosis of pneumonia. And for the but for the bacterial pneumonia, it is usually associated with lobar consolidation, as you can see as the patchy whitish opacity on the X-ray, and also in 10 to 30% of the cases, they might have also the characteristic of pleural effusion, such as the blunting of the costophrenic angle. As for the viral pneumonia, it is usually associated with diffuse tricky infiltrates of the bronchopneumonia and also hyperinflation. And also in atypical pneumonia, it might present with increased interstitial markings and also bronchopneumonia. So this is the example of in mycoplasma pneumonia with diffuse bilateral interstitial infiltrates. Next is the full blood count, particularly the white blood cell count, where in bacterial pneumonia, the white blood cell count is usually elevated, and it is predominantly polymorphonuclear cell leukocyte. And in viral, it might be normal or mildly elevated. As we can also do blood culture, it is a non-invasive gold standard for determining the precise etiologies, but it has low sensitivity, as only 10 to 30% of the patient have positive result. So it is indicated in severe pneumonia or if poor response to the first line antibiotic. Next is the renal profile. Renal profile, we look for any electrolyte imbalance, particularly in the severe pneumonia, as it can cause the syndrome of inappropriate secretion of ADH that can cause hyponatremia. And also we can do pleural fluid analysis. If there is significant pleural effusion, we can do the pleural tap or trachosynthesis, and this procedure can act as diagnostic or therapeutic. And also for this, we can do also the serological test. So as the atypical pneumonia usually occur in patients more than 5-year-old, this test should be considered in patients more than 5 years old. So next is the management of pneumonia. It can be divided into two, which are the supportive treatment and also specific treatment, which are the medications. First is the fluids. We can give the fluids, but we need to withhold oral intake in severe respiratory distress. And also we need to avoid overhydrating the patient, as the patient in severe pneumonia, there is increase in ADH secretion. So the dehydration is uncommon. Next is the oxygen. We need to maintain the SpO2 more than 95%. So we can give oxygen in patient especially with patient in severe pneumonia. And for the parasite, we can give also temperature control, such as the paracetamol, and also chest physiotherapy, where it can assist in the removal of the tracheobronchial secretion. As for the specific treatment, which is the medications, as majority of cases is caused by viral, and if we suspect the patient have viral infection, particularly in mild patient, there is no specific medication. As for the bacteria, we can give antibiotics. So this is the criteria for hospitalization of patient with pneumonia, such as age less than 3 months, whatever the severity, fever, fast breathing, failure of previous antibiotic therapy, recurrent pneumonia, and also severe underlying illness such as immunodeficiency. So for the inpatient management, particularly in patients with severe pneumonia, we usually give the broad spectrum antibiotics. And the first line antibiotics is usually the beta-lactams, such as the benzopenicillin, amoxicillin, ampicillin, and also amoxicillin clavulanate. And the second line, such as the cephalosporin, it need to be considered if there are no signs of recovery or the patient remain toxic and ill with spiking temperature for 48 to 72 hours. And third line antibiotics include the carbapenem and other gentamicin and amikacin. And there's also antimicrobial agents specific to the pathogen, such as the penicillin and cephalosporin in Streptococcus pneumonia, ampicillin, chloramphenicol, and cephalosporin in Haemophilus influenza type B, cloxacillin in Staphylococcus aureus, there's penicillin and cephalosporin in group A Streptococcus. As for the atypical pneumonia, we use the macrolides such as the erythromycin and also azithromycin, as these pathogens have a response to the beta-lactam antibiotics. So for the outpatient management, it is particularly in patients with mild pneumonia, and in this patient, the oral antibiotics can be prescribed, and we need to educate the parents and caregivers about the management of fever, how to prevent dehydration, and also how to identify the signs of deterioration. And the child should return in 2 days for reassessment or earlier if the condition is getting worse. And lastly is the complications of pneumonia, which include the pneumonia infusion, empyema, bronchiectasis, and also lung abscess. That's all. Thank you.
Okay. Any questions to the presenter? Any questions? Oh, 15 minit dia present. Bagus. Any questions?
Doctor.
Ask the presenter dulu.
This question with regard to the requirement for admission. Can just now there's a few indication kan, criteria kan. Means if it fit even one we need to hospitalize ke dia ada multiple baru kita hospitalize, macam recurrent pneumonia aja kita terus hospitalize ke macam mana? Macam
you need to use your brain lah basically. So kalau dah pernah work up for the recurrent pneumonia, so the thing is recurrent pneumonia, okay. Recurrent pneumonia is among the red herrings for primary immunodeficiency. Faham tak? There are certain things. So why we need to admit recurrent pneumonia? Because we need to work out why this child, should the child have recurrent pneumonia? Shouldn't lah, kan? How many times a child can be down with coryza? How many times per year? How many times a year if a child have pharyngitis or coryza symptoms? How many times per year? Still considered normal?
Once or twice.
Once or twice. Sabah kata one or twice. Orang lain? Bawah sekali nama Nur Aida. Siapa ni? Nur Aida Rose. Siapa ni? How many times? The answer is it depends on the exposure lah. If you send a child to nursery, for example, if you send a child to kindergarten, that child can have 10 to 12 times per year coryza symptoms, and that is still considered as normal. But there are certain things which we consider as red herrings for primary immunodeficiency. If the children presents with these symptoms, you need to work up for primary immunodeficiency. Kan? For example, 2 or more recurrent pneumonias per year. If the child has 2 or more recurrent pneumonias per year, you need to work up for primary deficiency. If the child has 2 or more deep-seated abscess per year, if the child has 2 or more otitis media per year, if the child has 2 or more infection needing antibiotic per year, these are all red herrings for primary immunodeficiency. If the child presents with these symptoms, you need to work up for primary immunodeficiency. I'm not going to go into what are the examples of primary immunodeficiency lah, but you should have some idea lah, macam SCID. SCID is a severe combined immunodeficiency. So there's several things. Job syndrome. Job syndrome is hyper IgE. These are all primary immunodeficiency. Okay, fine. So basically you need to use your brain. So it depends as well, meaning ideally even if the child has one of this, you need to actually admit and work up. But if it's already been worked up, then you need to think lah. But most of the time, patient who has these symptoms, you need to admit lah. If the child refuses to eat and the child is vomiting, so obviously you cannot allow the patient to go home lah, because the child will be dehydrated, kan? If the child is tachypneic, so if you allow the patient to go home, the child will deteriorate, isn't it? Kan? If the child is already on antibiotic and doesn't respond, so what's the purpose of allowing home with another antibiotic? Isn't it? So how many times you want to fail? Muslim shouldn't fail twice. Yeah, you should not fail twice. Kan? So if the patient has severe underlying illness, so why are you going to risk? So these are things. Patients less than 3 months old, you know, less than 3 months old, the symptoms are more subtle. When the symptoms are more subtle, you may miss things. So that is why, and they are basically immunodeficient lah. And so that's the reason why. Okay, all right, clear. Any other question? Before I ask questions. Okay, fine. If you have a patient with pneumonia, if you auscultate the lung, what can you hear?
Crepitation.
Crepitations or crackles. Orang kampung panggil crackles.
Crackles.
And so why can you hear crackles? Why? What is crackles? What is crepitations? Kenapa?
Gurgling sound bila ada fluid atau
yes, so because of the movement of the fluids kan? Movement of the fluids. But you need to remember sometimes because of excessive secretion as well. So crepitation dia more towards periphery. Dia more towards it doesn't change much. Tapi kalau bila banyak secretion, upper airway secretion, sometimes you can hear macam bunyi crepitation juga. So how to differentiate? Sometimes you ask the patient to cough. Cuba cough. Kalau dia cough, lepas tu bunyi tu hilang. So that means the secretion is just upper airway secretion. It's not lower airway.
Oh.
Kalau bunyi so patient tu cough. Bila cough, bunyi tu hilang. So it's probably an upper airway punya secretion. Tapi if the secretion and everything is lower down, you can hear the crackles. Fine or coarse crackles? Pneumonia, fine crepitation ke coarse crepitation? Coarse crepitation. What disease causes fine crepitation? Huh?
Lung fibrosis.
Lung fibrosis, okay. Bronchiectasis, sometimes you can have fine crepitation. Bronchiolitis, you can have fine crepitations. Bronchiolitis. Okay. I think our previous discussion was about bronchiolitis kan? Isn't it? Okay. What else? Patient with pneumonia, you put stethoscope, you auscultate. Okay, you said first is crepitations. What else?
Reduce bronchial breath sound.
Okay, yes, I was waiting for that. So why Why? Why? When you have consolidation, when you have a pneumonia, you'll hear bronchial breath sound. Why? Sebab
Because
apa?
of the transmitted sound from the bronchial.
Yes, very true. I like that answer. So bronchial breath sound is actually a normal breath sound. If you put your stethoscope in normal patient, if you put your stethoscope at the peripheries, what can you hear? You'll hear vesicular breath sound. Again, breath sound are caused by turbulent flow. Kan? The moment you put, because the flow is laminar, but there is some turbulence, so you can hear vesicular breath sound. The moment you put your stethoscope on the midline where the trachea is, where the main bronchus is, you hear bronchial breath sound. Why bronchial breath sound? Because of lower pitch, lower frequency, more turbulent, kan? So you hear bronchial breath sound. Okay, so bila ada pneumonia, kenapa? Sebab we already know, kan? You ingat tak Rini and Weber test? How do you do Rini and Weber test? Huh?
Air conduction ataupun bone conduction.
Yes, because Rini and Weber's test, you test for conduction of vibration, conduction of sound. And we know from doing that test, bone conduction is better. Kan? Tang, you dengar, tak dengar. Kan? Tang, you letak atas bone, you dengar walaupun letak jauh. Kan? Sebab bone conduction is better. So, you know, vibration, sound is caused by vibration. Solid carries vibration best. Air can carry vibration, can carry sound. Fluid is the worst in terms of a conduction of vibration. Kan? Okay. So, bila ada consolidation, nama pun solidification. Kan? Consolidation, there is solidification. So, bunyi itu is at your bronchial area, is at your midline. But because of the presence of solid particles, so this solidification carries the vibration from the central. So that is why when there's consolidation, when there's pneumonia, you can hear bronchial breath sound. So that is a transmitted type of sound that you can hear. Okay. All right. Okay. So if you percuss a patient with pneumonia, if you percuss, what will you appreciate? What can you find from percussion?
Dullness on percussion.
Why dull on percussion? Why not
Because
stony dull? Solid kan? Stone kan solid.
Stony dull kalau air.
Air.
Bukan.
Sudah.
Bukan.
Spelling sama tapi bahasa Melayu.
Air.
Itu pun lambat.
Because of fluid.
Okay, so kenapa? Why when there's pneumonia dia dull? Ada jawapan kat situ. Kenapa? Why? Anyone wants to try?
Because in water it can absorb vibration, so it will produce stony dull.
Okay, alright. So kalau ada air, kalau ada pneumothorax for example, if you percuss, what's gonna happen?
Hyperresonance.
Hyperresonance. Why hyperresonance?
Because
Best to air.
What happens bila you percuss? What happens? You create vibration. You percuss, you create vibration. There's a layer of surface which is the chest wall, the bones and things. This is the surface. Below this is air. Bila you percuss, you create vibration. When there is air, dia akan vibrate more. Bila dia vibrate more, it causes hyperresonance. Bila dia ada solid, will it vibrate? It will vibrate, but the vibration will be obtunded by the solid. Sebab tu dia dull. Bila dia obtunded, dia dull. Sebab this solid dia vibrate. Solid can vibrate. Tapi the vibration is reduced. It's obtunded. So dia jadi dull. Tapi bila ada water, ada fluid kat bawah dia, surface ada fluid. You know fluid has counter pressure. Fluid has counter pressure. Dia points toward up. Sebab itu kita boleh letak kapal, boleh letak kayu, dia terapung kan. Because fluid has counter pressure. It pushes up. Fluid pushes up. Counter pressure. So this surface, bawah ni ada fluid yang ada counter pressure. Bila you pekas, you push ke bawah, there's counter pressure. So this causes stony dullness on percussion. Okay, so my point is understand pathophysio. The problem is some student dia selalu confuse. Yang mana jadi dull, yang mana jadi stony dull, yang mana jadi, sebab masa belajar ingat. Tapi lepas tu sebab exam lambat lagi ataupun terbolah time exam, genaling, terbolah, Melaka semua kan, semua perkataan keluar. Lepas tu dia pun stony dull dekat masa kita tanya soalan. Kan? So sometimes student get confused. So my suggestion is, okay, you can hafal. You can hafal everything, but the better way is actually to understand. If you understand the pathophysiology, you may answer a bit later sebab you need to think. But then your answer will most likely be correct because you understand the pathophysiology. You understand the physics behind the sound. When you understand, you won't get confused. It is not shakeable because it is your understanding. Tapi bila hafal, it's okay. Siapa yang biasa dia power hafalan, you can hafal. But the way how I work, I'm not good at remembering things. I'm not good at memorizing things. So I prefer to understand. If you understand, it's not shakeable. Okay? So understand the pathophysiology. Sama juga. How about vocal resonance, vocal phragmites? Kalau ada pneumonia, vocal resonance, vocal phragmites, what's going to happen?
Increase.
Increase. Kenapa increase?
Increase. Sebab dia solid.
Aha.
So dia vibrate.
Kalau ada air, kalau ada pneumothorax, increase ke reduce? Vocal resonance.
Reduce.
Kenapa reduce?
Sebab dia poor conduction of the sound.
So solid carries sound better. So bila ada pneumonia you akan hear more. Tapi bila ada pneumothorax, tak adalah, reduce lah. Kenapa reduce? Satu ni sebab air doesn't conduct sound, doesn't conduct vibration well. Nombor dua, because there's no lung fill. Bila ada pneumothorax, there's no lung fill there. Bila tak ada lung fill, apa-apa bunyi dekat atas ke kat mana ke, you won't hear lah. Sebab there's no lung there. Kan? So kalau ada fluid, what's gonna happen? Kalau ada pleural effusion, for example, what's gonna happen to vocal resonance, vocal phragmites?
Reduce.
Kenapa reduce?
Sebab poor conduction of the vibration.
Sebab fluid is the worst conductor of vibration. Fluid is the worst conductor of sound. Fluid is the worst conductor of vibration. Fluid is the worst conductor of sound. So that is why you can't hit, it will reduce, and some more it will push the lung fill elsewhere. So there's no lung there. Tak ada lung kat situ. So apa sound yang nak dengar? So understand the pathophysiology. Okay. Clear? 10:30. 1.5 hour. Okay lah. Just nice. Any other question?
Tak ada, cuma tadi doktor suruh ingatkan yang nak bincang ada sound.
Dia dah bincang dah.
Yang sekali kan ni? Okay. Tak takut ada yang lain.
Ada sound yang lain Dia ada sound yang lain dah. For example, stertor. What is stertor?
Is it snoring, Doctor?
Stertor is an upper airway sound. Contohnya orang yang ada blocked nose, ada enlarged turbinate, so sometimes dia ada bunyi stertor. Stertor is a nasal sound. Kan? So it's not stridor. Stridor is at the level of your epiglottis, larynx kat situ, atau level your upper trachea, that is stridor. Tapi level yang higher and above your neck ni, dia akan jadi stertor. So dia sebenarnya everything is the same. So kalau bunyi dekat nasal ni dia bunyi macam mana? Kalau bunyi dekat belakang tekak ni bunyi dia macam mana? Bunyi kat bawah lagi dekat belah your epiglottis semua bunyi dia macam mana? Trachea bunyi dia macam mana? Lower down lagi macam mana? Oh, name me one cause of stridor that is caused by something cardiovascular. One cardiovascular disease that can cause stridor. Any idea?
Vascular compression.
Vascular ring. So vascular ring can cause stridor sebab your aortic root, dia goes around your trachea. So your trachea, your aorta and the vessel semua dia basically compress on the trachea. So when they compress on the trachea, you'll have stridor. So vascular ring. So if you have stridor, but it doesn't change with position. Sebab kalau macam laryngomalacia, dia akan change with position. Kan? And there's no signs of infection. Viral croup ada infection. But there's no sign of infection. There's nothing suggestive of infection. And then it has been persistent daripada birth sampai sekarang, still ada that persistent sound. Kan? It doesn't change with infection. So probably it is something that is structural. So the structure among the things that you need to think of is actually vascular ring. Bukan super ring vascular ring. Tak tahu super ring. Aduh. Okeylah. Nak pergi makan super ring.
Doctor? Doctor, do you know about the conducted sound in pediatrics? Conducted sound.
Conducted sound, yes.
In pediatrics, it is the first time I heard conducted sound. So it's really.
So Haila ni soalan dia putus-putus You always unmute yourself. Tak dengar soalan apa ni. Tak dengar kan soalan ni kan? Dia tengah ada soalan ke apa ni? Conducted sound, transmitted sound. So conducted sound or transmitted sound. So basically when you auscultate, so the problem with pediatric ni, dia orang ni kecil. Dia orang ni kecil. Dah lah dia orang ni kecil. You punya stetoskop pula bapak lah besarnya kan. You punya stetoskop tu bapak besar, lepas tu budak tu kecil je kan. So bila you auscultate, you put your stethoscope on the baby's on the patient's chest. Sometimes what you hear is not the sound from the area that you put your stethoscope on. Sometimes it is a transmitted sound, because again, as I told you, sound is vibration, and vibration is conducted from somewhere. It can be conducted by air, it can be conducted by consolidation, it can even be conducted by fluid. Fluid is not a good conductor, but it still can conduct vibration. It still can transmit sound. So, especially when you have a high amplitude sound. So, high amplitude means the level, the decibel there is higher. High amplitude. Frequency is pitch. Frequency means pitch. High frequency, wheeze. Low frequency, stridor, stertor. Tapi kalau amplitude means sound, dia punya volume or decibel kan. So sometimes if it is a high decibel punya sound, for example, contohnya dia ada upper airway punya secretion kan, upper airway punya secretion bunyi gegeli lah kan. So kalau ada banyak upper airway secretion, dekat trachea ada banyak secretion, for example. If you auscultate even at the periphery, you can hear the sound, but that sound is actually from the trachea. It's not at the site where you put your stethoscope on, because it is a transmitted sound. So how to differentiate a transmitted sound and also consolidation or crepitation from that particular site? I've said just now actually. Macam mana? Macam mana nak differentiate? Ayo, I've said. Sedih aku.
Ask the patient to cough.
Yes, you ask the patient to cough. Acu batuk sikit kan. So bila patient cough, kalau ada secretion, dia akan move the secretion about. Kan? Kalau patient tu tak boleh cough, newborn baby, infant, batuk, you suruh baby tu batuk. Kan? Patutnya you lah yang kena luku kepala kan, sebab you nak suruh baby cough. Macam mana bukannya dia faham kan? So in a bigger child, you bolehlah suruh dia cough. But in smaller child, you cannot ask them to cough. So what can you do?
Stop.
Boleh buat apa? Yes, you can do chest physio. You can do suctioning. You can do chest physio. Chest physio you boleh buat vibrate percussion or you boleh buat vibration. Kan? So bila you buat physio, you will move the secretion about. So bila you move the secretion about, the sound will change lah, because secretion, cause of the sound tu dah pergi tempat lain. So if you do this, the sound changes, then most likely this is a transmitted sound, meaning sound that is transmitted from somewhere, not because of that particular lesion or something. So this is transmitted sound. In adult tak sangat transmitted sound. Boleh je transmitted sound daripada adult ni. Tapi usually no. Kenapa? Sebab adult ni besar. Kan? Adult ni besar. But children, they're very small. Especially kalau you pakai you all punya stethoscope kan. Bapak lah besarnya. Okay. Alright. Okay, I think that's all lah. Tomorrow we have one long case session, isn't it, with one of the groups. Okay, alright. Let's end our session with tasbih kafarah surah. Okay, assalamualaikum.